Dr. Gaurav Luthra, speaking on his journey of 10 years with cross-linking.
So, very good morning, everyone. And at the outset, I would like to congratulate the NN team and Rohit for a wonderful meeting this time and this new format. And it's interesting to experiment with this format as well. And I'm sure this is going to lead to more and more innovation coming out of NN and for other societies to follow. So when we started out for this meeting, and Rohit and me were in Hong Kong a couple of months back, and I was presenting my data of 10, 12 years of cross-linking, and he said, why don't you come out and present? I said, your meeting is going to be full of all innovations, and you want me to talk on all the historical stuff that we've been doing, so it's going to be a little boring. But then I think picked up a few things on the way, and thought I'll share that with all of you. And so it's actually been a little longer than the 10 years. And so we started somewhere in 2006. Now, if you look back to keratoconus, it's not so long back that there was no cross-linking. So in fact, I think it was around, while research had been on for a long time, it was somewhere around 2005 or 6 when in India we started doing our first cases. And surprisingly enough, the first 3 cross-linking treatments in India were actually done at a live surgery in my city of Dehradun, where we managed to convince Hans-Peter Iseli, who was working in the Theo Seiler group, to sneak in his machine in a briefcase. And there was no machine available that time in India, and we did those first 3 cases, and it was quite unique because we'd been reading for cross-linking 2-3 years already. And so we still have one of those patients on follow-up with us. 2 of them are lost. And this was the protocol that we started out with. Everybody will be familiar who's used the IROC machine. And this was the traditional Dresden protocol that we would follow. It worked pretty well, and we learned over a few years how traditional cross-linking would work. This is the scan from our first patient. We do not have scans from 2006 to maybe 9, and I think the first scan probably is from somewhere in 2008. Yes, and then we have this recent scan from somewhere in 2015. So you can see the right eye was the one which was treated, and it's held on. The patient is doing pretty well. We haven't seen any significant changes in the right eye, so apparently we did a good job, and this patient did have documented progression before we actually treated him. Now the funny thing is that this all looks really nice. Look at what happened in the left eye. We did not treat the left eye. It had inferior steepening and had a grade 1, grade 2 keratoconus. Look at this map here, and you'll see a flattening. All we did was counsel the patient. There was no treatment, and all we did was counsel the patient. He had seasonal allergy. He came to us as a young boy, probably about 15, 16 years old. So no cross-linking, and just the awareness and the counseling of good allergy treatment, and that's probably being covered in a few other talks. So while the right eye did really well, so did the left. No treatment done, and has flattened over the last 10 years for no reason apparently. So we started, there was a lot of interest, and accelerated protocols started coming in somewhere in 2009, 10 and 11. We acquired one in 2011. This was the Peshke unit, I think. And suddenly we had, there was a lot of interest on how fast you can cross-link, whether you can use the 30 milliwatt protocol. The Avedro protocols were there, and then some of our machines had only the 18 milliwatt, which could be done for 5 minutes or maybe 10 minutes. So we started studying these different protocols, and we actually did a comparison for the 5 minutes and the 10 minutes with the 18 and the 9 milliwatts over a period of about 2 years. And at the end of that study, which we did for about 70 odd eyes, we realized that we were getting better cross-linking effects, although there was no way to measure it. So, we were not equipped to actually, so this is more like something which comes out of what we observed rather than we studied in more detail. But we found that the 9 milliwatt protocol was working better for us. And I remember we kept on exchanging notes with Rohit and few of my other friends who were doing cross-linking as well. So after the initial excitement about the high effluence treatments and the short treatments, I think we all kind of settled down, and now we restrict ourselves more to the 9 milliwatt 10-minute protocols. It's quite patient friendly, and it helps, and you can see that lots of different people have suggested different protocols for using the drops at the bottom there. And if you'll notice that there's different protocols, so you have to make sure that your corneal penetration is good, and some of these recommended protocols don't work, and I always prefer to check patients on the slit lamp. And you can see that this was the year after that we started doing epi-on treatments again somewhere in 2012. Now again, this was very interesting because we all realize that patients, once you have the epithelium removal and then the healing process and the contact lens and the risks associated with taking the epithelium off, and then pediatric patients, so there was a lot of hope and that the epi-on treatments would work. In fact, I think the US FDA trials were all done on the epi-on protocols as well, and surprisingly enough, the FDA approvals came only in 2016, and I think they still have access only to the epi-on treatments. So we delved ourselves as well on the epi-on treatments. There were suggested advantages, less invasive, as I said, visual recovery was thought to be very fast, but frankly these were the options where you would actually feel that transepithelial CXL would be better, thinner corneas, post-LASIK ectasia, pediatric cross-linking, better compliances, faster recovery, and maybe less invasive. Now, in our experience, we treated about 56 eyes from 2012 to 2015, after which we slowed down, and this was the age groups from 9 to 29 years. So definitely pain scores were less, patients were much happier to begin with, and everything looked really nice. But we did experience epithelial breakdowns, and we had patients who would require a contact lens on the day 2 or day 3. So towards the end, I remember we started actually putting in a prophylactic contact lens to all our patients because they would have significant irritation, and maybe the dye we were using was probably different from what is available today. But towards the end of that period, when we reached 2015, we realized that we were probably not doing such a great job with the epi-on protocols as FEKVC wise we were doing with the epi-off, and the OCT pictures showed that the compacting of the stroma was probably not as great, and it was restricted to the more anterior part than with the traditional cross-linking. So our enhancement rates with the epi-on, we enhanced eventually 6 out of the 56 eyes that we had treated, and it usually would start at about, the progression in our patients was somewhere between 18 to 24 months typically, and the average age group was of the patients selected for epi-on treatments, because we were initially using more on the pediatric age group. So there are biases. When I say 6 out of 56 eyes, there will be a selection bias, and we were treating, of course we were also treating grade of keratoconus was less severe. For the really advanced keratoconus, we were actually using the epi-off technique as well. So there may be a bias and there may be a reverse bias, and now we post 2015 restrict ourselves for epi-on treatments to very select indications. This was a case which I thought I would share. There was a 27 years old male with documented progression in both eyes over 1 year. He was very keen because he was visiting from the US. He had been reading all the stuff on the FDA trials, and he did not want an epi-off treatment. He was the son of a renowned orthopedic surgeon in my city. We did an epi-on treatment. His father said definitely epi-on. We went ahead, did that. We got at the 1 year follow-up, we had good flattening effect, and however, he came back at about 1.5 or 2 years with progression in one eye, and the other eye looked good. And eventually in 2016 we enhanced his right eye epi-off, and this was his follow-up. So if you'll see, this is on top the latest one, and if you'll see, this is a subtraction, I think, between C and D. So you'll notice that there was a progression, and this was between the 2015 and this is a subtraction between the 2015 and the 2013 when he was treated. Now this was subsequently, now this is the 2017 compared to the 2015, and we've seen that epi-off resulted in some flattening as well. So we actually follow up all our keratoconus patients. I think I have a huge database now of all these patients. This is a fellow eye which holds up and does pretty well, was also treated epi-on. So epi-off, we did many more cases. We've done 800, maybe now at about 1,000 patients. 5 out of those had progression and they were enhanced, and 2 of them had bilateral enhancement. And progression typically started between the 5 to 7 years, and some of them had reasons, and so they had all remained stable on follow-up for almost 5 years. And of course, out of these 800 odd patients, we have on follow-up just about maybe 250 or 300 patients as per our current this thing. And not all patients are on follow-up, even though we insist on annual follow-ups for all our treated patients now. One girl, she progressed after pregnancy. She had been cross-linked, was doing well for almost 5 years, and she had progression. She was settled in the UK. Her doctors there in Moorfields refused to enhance her. She had to actually come back, seek enhancement because she was losing vision. So they've all been enhanced. They're all stable on treatment. And this is the map from that girl whom I was talking about. This is post-epi-off enhancement done about 5 years back. She continues to do well in both eyes. We enhanced her, and these are the maps from there. So epi-on versus epi-off, I think no doubt that for us, epi-off is more effective than epi-on. I am aware that in the US, I've been interacting with a lot of our US surgeons. They are using some proprietary new riboflavin formulation, which apparently for them works much better and has given them excellent results. They've documented it, so I'm sure that epi-on continues to work very well for the US surgeons for whatever reason. And for us, there's a 10% enhancement rate in epi-on treatments compared to just below 1% for our epi-off. That's from our center. So I won't talk on the pediatric, and I'll try to finish off. We do a meticulous follow-up of all our keratoconus patients. In the first 3 years, we would want to see them every 6 months, and then at least annually after that. And I'll be finishing off in 2 minutes, in 1 minute maybe. I wanted to share one interesting patient from towards the end. So one very important message from these, whatever I've learned in these 10, 12 years, we avoid advising cross-linking to a patient on the first consult. This is very important, and we have n number of cases now who have come to us, advise cross-linking elsewhere, and then come for a cross opinion. Some of them we've decided to just put them on follow-up, and many of them actually go on with proper treatment of allergy and proper treatment of, if they have allergy that is, and about eye rubbing, and they sometimes don't need treatments, and some of them will flatten as we just discussed. Pediatric age group, of course, the threshold is much lower. And definitely what we picked up over the years is that avoid treating patients who have unaided 6/6 vision with early keratoconus who may show progression. Some of them will actually lose 1 line of vision post cross-linking, or even 2 lines, and they're not going to be happy patients at all. I'll skip this case, which was a post-LASIK ectasia, 18 years post-op, again attributed to eye rubbing. Eventually that we found out he used to be rubbing his right eye, and he went on to develop ectasia in only 1 eye. But if you look at his maps on the fellow eye, you'll notice posterior elevation, which would show this small on the posterior elevation map, showing you a small bump there, but nothing overt. So let's come to our last slides. This is a small thing we've been following for our thin corneas. On topography, we pick up the cone and then sometimes we will leave bend. So we've experimented with contact lens assisted cross-linking, and now we are doing with some lenticule assisted cross-linking, and then we've been using this small epithelial island, but you have to be very careful that you get enough penetration of dye between that. So I think thin cones between 300 to 400 microns can be done using this. We've now got data about 3 years. These patients are doing well with cross-linking, and we've got fairly good effect of the cross-linking. And only thing is you have to be very careful about these thin corneas. Pachymetry can drop drastically when you're treating them, and always check intraoperative pachymetry and check for drying. So I think I'll stop here, and we've kind of gone through this journey, and it's very exciting. And when you listen to all that is being done at so many places, it's difficult to imagine that just about 10 years back we had no access to 10 to 12 years back, at least we had no access to cross-linking, and now we take it for granted that cross-linking is probably such an easy thing to do. In fact, keratoconus patients have had their lives changed tremendously with all that's happening and all that is going to happen as we've been listening to. And with that, I'll stop here. Thank you so much.